but open the joint, reduce the dislocation, and fix. So there is no decompression, no decompression. Sorry for this. No. Sorry. There is some mismanagement here of my slides. Okay. So reduction of fixed dislocation is a very fantastic technique. So there is transoral surgery we all used to do, but now you can reduce the dislocation and there is then fixation. This is another case of fixed atlantoaxial dislocation, which was called fixed, but this can be reduced by opening the joint and doing direct atlantoaxial fixation. Basler invagination, this Basler invagination is a complex subject. In the year 1998, we wrote this article that Basler invagination is of two types. Group 1, when the odontoid process goes up, and 1, 2, then the tonsil comes down. This goes up, this comes down. So these are two entities we described in the year 1998. We said transoral decompression for this and foramen magnum decompression for this. In 1998, the concept about basilar invagination was that all these patients have fixed dislocation. Because the dislocation is fixed, decompression was the treatment. So you do transoral decompression or foramen magnum decompression. So this was the treatment in 1998. And we said that there is a small posterior cranial fossa and you should do bone decompression. There is no need to open the dura in these cases for the first time in literature. In 2004, you see, in 2004, we said that there is no need to do transoral decompression. You can open the joint and reduce the basilar invagination in 2004, and you can do craniovertebral junction realignment. And we propose that there is no need for transoral decompression. So this was the basilar invagination. And you see the basilar invagination, the odontoid process has come down and there is craniovertebral junction realignment. There is no decompression. There is basilar invagination, odontoid process is going up. So you can open the joint, distract the facet and reduce the basilar invagination. So this concept is now very popular concept for those who are doing basilar invagination surgery. You see, this is basilar invagination, and you reduce the invagination by opening the joint and distraction of the facet. So this is a very fantastic new concept. And this was my first case in the year 2000. So 20 years ago, I did this operation. This is the basilar invagination, and this is the craniovertebral junction realignment by opening the joint, distraction of the facet. So my concept was at that time that basilar invagination is like lumbosacral listhesis. This is C1 facet, C2 facet. So like lumbosacral listhesis, you have to treat basilar invagination by stabilization. Another very beautiful concept that we proposed was that short neck, torticollis, Klippel-Feil abnormality, bone fusions, C1 assimilation, C2-3 assimilation, bifid atlas, platybasia are all secondary to atlantoaxial dislocation. You do atlantoaxial stabilization the torticollis will return normal, the neck will become long, and there is a potential for bones to unfuse. So atlantoaxial instability is the primary problem. Musculoskeletal abnormalities are secondary and protective. So torticollis is protective, short neck is protective. You do atlantoaxial fixation. In the evening of operation, the neck can become straight and the neck can become long. This is another case. You see the torticollis and you see the long and straight neck, basilar invagination. You open the joint, do a good fixation. There is no need to do any decompression, and you can give new life to this person. New life, completely new life. This is another patient. You see basilar invagination. You do fixation, the neck. In the evening of operation, the neck can become long and neck can become straight. So now I have got several patients of this kind where we have done for torticollis and for short neck this kind of treatment. You see the treatment. This is the basilar invagination. Stabilization, atlantoaxial stabilization is the treatment. Bone fusions are not embryological problems. They are secondary to atlantoaxial instability. They are protective. This is a very big concept. So when there is bone fusion like this, it is not, this is not primary. You see, in extension, it comes down in flexion like a piston. So there is a vertical dislocation. So multiple bone fusion is never a primary phenomena. There can be vertical, reducible, mobile dislocation. Bifid anterior and posterior arch is not a primary embryological problem. They are natural solution. When you do flexion, the bifid opens. You do extension, the bifid closes. So bifid opening and closing is a dynamic phenomena. This we mentioned in our article. And when there is bifid, it means there is atlantoaxial instability. So there is a lateral dislocation of the facets when there is a bifid arch of atlas, lateral dislocation. So when there is multiple bone fusions and when there is a bifid atlas, even when there is no compression at the craniovertebral junction, atlantoaxial stabilization is the treatment, and you can give beautiful new life to these people. Syringomyelia is helpful phenomena. It is not harmful. I mentioned in this several papers of mine since the year 1996. I am saying that syringomyelia is not a problem. It is a natural protective phenomena. It indicates presence of atlantoaxial instability. Os odontoideum is another very complex subject. Not many people understand. You see, os odontoideum is an evidence of atlantoaxial instability, and the treatment is atlantoaxial stabilization. Occipital inclusion is not necessary. Transoral decompression is not necessary. This is another case of os odontoideum, and you have to do atlantoaxial fixation. There is no other treatment other than atlantoaxial stabilization. I introduce another very fantastic concept of central or axial dislocation. And I must, I must ask Dr. Hilmani too. I want to talk to you about multi-level spinal degeneration and central dislocation in my subsequent lecture. Atlantoaxial instability is a very common cause of multi-level spinal degeneration. So instability is always associated with basilar invagination. This we mentioned in the year 2012. And whether there is obvious atlantoaxial instability or not, atlantoaxial stabilization is the treatment. Central, now I want to discuss with you a new entity called central or axial atlantoaxial instability. You see these beautiful images. You see the facet of atlas is in front of facet of axis. So this dislocation will result in atlantodental interval disturbance and it needs atlantoaxial stabilization. Now you see the facet of atlas is behind the facet of axis. And this basilar invagination, the whole world will do foramen magnum decompression. But it is an unstable spine and it needs atlantoaxial stabilization. It is a difficult operation in this situation, but this is the treatment. Decompression is not necessary. There is no atlantodental interval disturbance. This is another case where is Chiari malformation, syringomyelia, the facets are normal, there is no tight posterior cranial fossa, but even this is type 3 dislocation. It needs atlantoaxial stabilization. The patient will improve in the evening of operation and the tonsil will go up and syringomyelia will reduce. So this is type 3 according to the facetal instability. Essentially, what I have mentioned is that basilar invagination is always a manifestation of atlantoaxial instability, and whether it is group A basilar invagination or whether it is group B basilar invagination, always there is one treatment, and that treatment is atlantoaxial stabilization. Even when there is very big basilar invagination like this, there is no need to do foramen magnum decompression. There is no atlantodental interval disturbance, but there is a facetal instability, and this patient needs atlantoaxial stabilization. Foramen magnum decompression or transoral decompression is not necessary. This is another case. You see the basilar invagination, Chiari malformation, syringomyelia, the facets are in normal position. There is no atlantodental interval disturbance. Atlantoaxial stabilization is the treatment. This is another case. There is no atlantodental interval disturbance. There is no facetal malalignment. There is no tight posterior fossa. Presence of Chiari malformation indicates the presence of atlantoaxial instability, and it indicates the need for atlantoaxial stabilization. So in my story now, transoral surgery is completely historical in our subject of neurosurgery. Completely, there is no indication other than tumors. Tumors, of course, is a different situation. Chiari malformation, you see, nobody in the world knows how to treat Chiari malformation. Foramen magnum decompression, dural decompression, tonsillectomy, and various kinds of treatment are recommended for Chiari malformation. So few years ago, I wrote that atlantoaxial instability is the cause of Chiari malformation and atlantoaxial stabilization is the treatment. This is a complete revolution in the field of neurosurgery, complete revolution in the field of Chiari malformation. All patients of Chiari malformation, not with those with tumors, not with those of hydrocephalus, not with craniostenosis, not type 2 Chiari, type 1 Chiari malformation, basilar invagination, syringomyelia, and Chiari formation are always due to atlantoaxial instability. So this is atlantoaxial unstable facets. There is Chiari malformation. There is syringomyelia. You have to do no decompression, no decompression. You do atlantoaxial fixation. The syringomyelia will reduce and the patient will improve in the evening of operation. So this concept is a new concept, and there were many arguments in the literature on this concept. And we said that Chiari malformation is like natural airbag. It is a protective phenomena. It is manifestation of potential or manifest atlantoaxial instability. So this, we should not call it malformation. We should call it Chiari formation. So this is the case I have shown you already. There is Chiari malformation. There is no atlantoaxial facetal instability or atlantodental instability. Atlantoaxial treatment fixation is the treatment. This is another case. The whole world today will do foramen magnum decompression. I am saying that is absolutely a wrong treatment. We describe that these patients have a tight posterior fossa. I describe myself, and I describe that you should do decompression in the year 1998. But now I am saying that presence of Chiari malformation and presence of syringomyelia are indicators of atlantoaxial instability. You stabilize the atlantoaxial joint, the syringomyelia can reduce in the immediate postoperative period, and 100% of time if you do an imaging after 1 year, syringomyelia reduction. So now I have got several hundred cases where I have done, including a president of an African country. I don't want to name this president. I did fixation. This is Chiari malformation, syringomyelia, no decompression, only fixation, and the syringomyelia reduces, and the tonsil goes up, and this is the form of treatment which is absolutely new philosophy in the treatment of Chiari malformation. Even in children, when there is Chiari malformation, I don't like to call it malformation, I like to call it formation. Atlantoaxial fixation is the treatment. You see, this is the child with Chiari malformation. This is syringomyelia. There is no atlantodental interval disturbance. This patient has already undergone foramen magnum decompression, and you do atlantoaxial stabilization. Syringomyelia reduces. More importantly, the patient improves dramatically in the evening of operation. This is a case of failed foramen magnum decompression. This patient was operated 13 times. Foramen magnum decompression, multiple syringostomy. See, there is a tube here, and there have been various kinds of treatment for this patient. And I did atlantoaxial stabilization surgery, as you can see here, and the syringomyelia reduced, and the patient improved dramatically in his neurological function. Treatment of idiopathic syrinx. You see, idiopathic syringomyelia, there is no Chiari malformation. There is mild evidence of facetal instability. You treat by atlantoaxial stabilization, and the syringomyelia can reduce, and the patient will improve dramatically in the clinical symptoms. So can foramen magnum decompression surgery become historical? So this was my recent article, and I'm absolutely convinced that for Chiari malformation, for syringomyelia, never open the syrinx, never open the bone. Decompression is a negative operation. So occipital bone fixation is a negative operation. C1C2 fixation is required in the cases of Basler invagination, in cases with syringomyelia, in cases with Chiari malformation. There is no need to do foramen magnum decompression. So this is my message to the Moroccan neurosurgeons. I hope this message is loud and clear, and I am sure there will be many questions, and I'm waiting to hear many questions from my Moroccan colleagues, and I will be my friend, Dr. Khalmiti. I can see him smiling, and I'm very happy to see him. Thank you very much for joining me. Thank you, dear friends.
Thank you, Professor Atul Gul. I will I will tell to Professor Khamlishi to tell you some words. I know that you are very good friends, Professor Khamlishi, before discussion. Micro, Monsieur Khamlishi, micro. Activez votre micro. En haut à droite. Audio.
Hein?
Voilà, c'est bon.
Vous m'entendez?
Oui, très bien.
Good afternoon, my dear friends. Thank you very much, Professor Azhari, for asking me to say some words. And thank you for all the organizers for this nice webinar. And of course, it's a great pleasure to see here and to hear our great friend, my great friend, Atul Gol, I think we meet maybe around 18 years ago.
That's right.
First
That's right.
time it was during your national congress in Chandigarh. You remember?
Yes, yeah, of course.
Yeah. After one very provocative question regarding my presentation on giant pituitary adenoma, you see, I still remember this our first time we meet. So really, thank you so much, my dear Atul, for this nice conference. As usual, very extensive knowledge, not only about this subject. Of course, you have talked on today, but it was always your habit in any other subject. A great neurosurgeon, an outstanding practitioner, and a large neurosurgical knowledge. And I think that my friend, Professor Azhari, remember just last year in Mumbai, we heard many of your conferences as you were the guest speaker of your national congress. You have shown us a lot of evolution in your technique, in your way to manage not only the atlanto-axial instability, but all cranial vertebral junction problems. Of course, you have give many argument regarding the success of the fixation in many other pathologies like Chiari malformation, like basilar impression, like syringomyelia. I think my question is to ask you, please, to give maybe some more physiopathology, which relate this instability, bone instability, to all these pathologies for our colleagues to understand that, because your surgical techniques, the result, of course, are convincing all of us. But if you can give us some more physiopathology to explain the relationship between these two entities, it's very important. And maybe my another second question for you and for Professor Hilmani, I am thinking again for this initiative to organize this webinar in this very special, complex, and difficult subject, is about the anatomical variation of the vertebral artery. How which kind of imaging helps you best to detect them, and of course to try to decide which kind of surgery you are going to do, and how to avoid, of course, the injury of the artery, which happened when we looked to the literature in about 5 to 8%. And also, did you have such severe accident in your practice, both of you? Thank you very much.
Thank you, Professor Hilmani. Professor Khamlishi, before to listen to Professor Hilmani, I would perhaps we will make some question. There is many question before, and if there is somebody want to ask Professor Atul Gul about something, because it's really new concept, and it's not new concept for him. It's concept of Atul Gul, but it's not for us. It's a new concept. But what I think is very nice is some people from India ask you through Casablanca to answer them in India. It's really amazing. It's amazing. It's this virus. I think he's educated us and to make communication between people. So somebody has a question. Which one? Professor Dr. Haku is Asifran.
أسفران نجيب.
Asifran.
أسفران نجيب.
Asfiran Najib. Okay. Go ahead.
What is the question?
Question Asfiran. Give him the audio, please, Dr. Haku.
It's not there. أسفران.
Okay, Professor Aitman Ali, and we will come back to Asfiran. Professor Aitman Ali.
Yes. Hello, everybody.
Hello.
Thank you, Professor Izhari. Thank you, Professor Goal and Professor Hilmani for this very nice presentation. Professor Atul Goel, my question is related to vertebral artery. About screw placement. If we have asymmetry of the vertebral arteries, do you recommend to start by the side where we have the smallest one, the small vertebral artery? And my second question, what to do if this vertebral artery is injured? Thank you.
See, the vertebral artery is a very important, people are afraid to do C1C2 fixation because there is a lot of venous bleeding in the region. That is one. And second thing is the vertebral artery can get damaged. So that is the most important. You see, vertebral artery, to identify where is the vertebral artery and how your screw will go is a very critical part of this operation. And of course, I have damaged on several occasions. I'm not saying I have not damaged. I have damaged on several occasions vertebral artery in my lifetime. I mentioned that I have done C1C2 fixation. I'm doing for the last 33 years. I am doing this operation. And I have done more than 2,700 of these operations in this time. And I have damaged vertebral artery on several occasions. So you can use navigation that is very important to use navigation if you in the initial part of your experience. Second thing is you have to know the anatomy very nicely. Before operation, you should do CT angiogram, MR angiogram to see the facet and see the vertebral artery, and your screw direction has to go very medially and superiorly. And now recently I have described, you see, I sometimes in very high vertebral artery, I expose the vertebral artery by drilling the posterior part and mobilizing the vertebral artery. I do this kind of technique, but vertebral artery management is a very critical part of this operation. So if you are doing the screw insertion and you damage the vertebral artery, then you have to rapidly tighten the screw and the matter will be closed. It is very unlikely that you can, in the screw, when you are putting the screw, you can repair the vertebral artery. If your vertebral artery is damaged laterally, then if it is damaged, you can put some sutures here and there. But when you have put in the direction of the screw, the vertebral artery, you have to just sacrifice the vertebral artery. Before I go further on vertebral artery, I want to answer one question of Professor Khalmichi. You see, he asked me, why atlantoaxial? See, atlantoaxial joint is the most mobile joint of the body. And atlantoaxial joint is the most unstable joint of the body. So instability is very common. So there are acute instability and there is chronic instability. Acute instability, there will be severe spasm of the neck and all those things. In chronic instability for 10 years, 15 years, there will be secondary maneuvering, secondary processes like shortening of the neck, torticollis, and then there will be bone fusions over a long period of time. There will be platybasia. There can be several things. And neural alterations include Chiari malformation and syringomyelia. So these are all secondary and naturally protective maneuvering. And we have to really understand this. We cannot just do without understanding decompression. Decompression is completely not a surgical treatment. So that is my understanding over the
Your
long period of time.
your concept. That is your concept. We know that, Professor Gold. Dr. Bouzouba?
Thank you to all the organizer and especially to the both presenter. Thank you for your excellent presentation. My question, I have two questions, but simple. What is the usefulness of the angiography, vertebral angiography before surgery regarding the great variability of the trajectory of this artery, especially when there are instability? This is the first question. The second is what's about the craniocervical traction, especially in infants? Thank you.
Yes. See, vertebral artery has got very variable relationship with the C2 pedicle and facets. So recently, I do 3D model printing, 3D model. So I can see the vertebral artery and I can see the bone in complex situations. But we have to do, see, I don't do digital subtraction angiography, but I do CT angiogram and I do MR angiography always to see where is the location of vertebral artery in relationship to the C1C2 facets so that I can introduce my screw in a proper fashion.
Thank you. Asfiran Najib, Asfiran Najib maintenant. Now. Sihko, Asfiran Najib.
Sorry,
Has the mic.
he didn't answer the second question about cervical traction.
Cervical traction, yes, cervical traction. You see, cervical traction I give only during the operation. I do these operations under traction. I never give preoperative traction. I never give postoperative traction. You see, for the rotatory dislocation in children, rotatory dislocation. So, and if there is an acute rotatory dislocation, sometimes you can give halo fixation, halo traction in children, sometimes to see, because in traction it can reduce this rotatory dislocation. Otherwise, I do not give preoperative traction in any patient.
Okay, Asfiran.
Dr. Asfiran, you can ask.
There is one
Ahmed
question.
Nasir. Ahmed Nasir.
Thank you, Professor, for a very wonderful presentation. I think you introduced a concept of Chiari malformation because I know most arguments has always been between whether to open the dura or not. I just wanted you to expound how, in terms of the pathomechanics of opening, of doing an atlantoaxial instability, what's in the background of Chiari 1 malformation? Thank you.
See, now, you know what? This is a big concept, Chiari malformation. Tomorrow, I'm going to give one webinar here in India on Chiari malformation revolution. I wish you can join, or I can speak on another occasion for full 1 hour to give my discussion on Chiari malformation. I will request you to please organize after 1 week, one more webinar for me. And I want to talk only on Chiari malformation. You please do it because it is very important subject.
You are welcome.
And I will be more than happy to join you. So next week, if you can organize. If you cannot organize, let me answer this young boy's question. You see, opening of the dura, opening of the bone, removal of the tonsil, opening of the arachnoid. There are many forms of foramen magnum decompression that have been described in the literature. In 1998, my first time I said that you should not open the dura, 1998. And then there are many people who are not opening the dura. But now, today, in 2020, I am absolutely clear in my mind And I want you young people to understand. You see, everybody can argue and discuss and all those things. What I want the young people in Morocco to learn is how to do atlantoaxial fixation. You learn this technique. It is a difficult technique. You know, it is not easy technique to do C1C2 direct fixation. Learn the art of opening the joint. Learn the art of, introduction of screws in C1, in C2, opening the joint, introduction of bone graft. You learn this technique. And then if you learn this technique, you will find more and more indications of this technique. I can tell you today, Chiari formation, the treatment is no bone decompression, no dura decompression. And I have told you very high profile people I have operated recently, and very effectively I have done this treatment.
Thank you. There's some question.
Yes,
How do you deal? It's from in Nasuru Ismail. How do you deal with C2 nerve?
C2 ganglion. C2 ganglion is located behind the atlantoaxial joint. Just behind, and it is quite a big ganglion, about 1 centimeter in thickness. So when you are going, this ganglion can disturb your vision. So I recommended in 1988 to cut the ganglion to expose the joint. And to cut the C2 neurectomy is quite a straightforward technique. It gives you a very beautiful vision to the atlantoaxial joint. But you don't have to cut if you can mobilize the ganglion up. Nowadays, I don't cut. But this C2 ganglion was first described by me to cut the ganglion and expose the joint. I do not do it in all cases, but in complex cases, I still do C2 ganglion resection.
There one very.
There is Professor Wahabi want to speak.
Professor Wahabi, please for everybody, you can just
raise your hand.
Raise your hand.
Thank
to
you.
see
Thank you.
Sorry,
Thank
Professor Wahabi. Sorry.
Thank you, Professor Azhari. Thank you, Professor Hilmani. Thank you for Professor Gould. This is a fantastic conference. I have two questions. One is a technical one. Do you make any difference in the management of craniovertebral malformation with reductible instability versus non-reductible instability? That you make change your technique? This is my first question. My second question is, we have seen and have attended many of your conferences. You have been evolving in the concepts of the pathophysiology of this area. This is because there is development of neuroimaging technique, or because you review your techniques and results, you are not satisfied, and maybe in the future we will expect other approach. What do you think? How do you there have always been some resistance in the audience, and you have discussion in some conferences. Do you think you will convince more with time this people?
Okay, let me answer your questions. One thing is reducible and irreducible. You see, this my article, I said there is nothing irreducible. You can open the joint and manipulate the facet and make it, reduce it on table. And this is completely a revolutionary concept, and the whole world is now agreeable to this concept that irreducible is not an entity. Open the joint, distract the facet, introduce bone graft, manipulate the facet, and you can reduce irreducible dislocation. So my technique is, whether it is reducible or not reducible, I always open the joint, I always put the bone graft, and I always do fixation. So that is one this thing. Second thing is, as you know, I have been the atlantoaxial fixation I described in 1988 when I was a very junior consultant. I was, 32 years younger than what you are seeing me now. And then I evolved slowly, more and more experience, more and more experience. You see, now I'm getting so many patients. Today, I can tell you without any hesitation, without any confusion in my mind that all young people at least should learn atlantoaxial fixation. Because the indications of atlantoaxial fixation is not only in Chiari malformation, it is also in degenerative cervical spondylosis. And also I will give you to Moroccan doctors one more lecture. You please organize one more lecture where I want to talk on degenerative spine some other time, of course. So in Chiari malformation, you do atlantoaxial fixation properly. You see, you don't do suboptimal fixation. If you do a strong fixation, in the evening of operation, the patient will improve to an extent that you cannot imagine. He will get a new life after surgery. And I have seen all kinds of treatment. I have done decompressions, I have done transoral decompression, I have done all kinds of treatment. Atlantoaxial solid fixation, this I think is the final answer for the treatment of Chiari formations.
Thank you. The two questions are very interesting. One, it's joined the question of Professor Khamlishi is why the strengths improve after fixation? What is the mechanism? That is the first question. And the second question, the same. People is which implant you use?
Okay, so let me talk on more important subject, and that is why syrinx reduces. You see, my concept is syringomyelia is not a primary process. Tonsillar herniation is not a primary process. It is a secondary process to atlantoaxial chronic dislocation. There is chronic dislocation, and syringomyelia is a protective natural phenomena. Tonsillar herniation is a natural phenomenon. This is my concept. And now I have got an experience of several hundred patients. And now today I am saying in 100% patients, the syringomyelia will reduce after 1 year if you do MRI. And there will be 15% of patients, the syringomyelia will reduce in the first week of operation. So there is, if you have any confusion or any doubt about this, you do syringostomy operation, it is a negative operation. You do shunt in the syringomyelia, it is a completely negative operation. I am telling you, you please believe me, my dear Moroccan friends, you please believe me, don't introduce syringo subarachnoid shunt or any kind of shunt. That is a negative operation. Reduction of syringomyelia, 100%. Clinical improvement, 100%. You tell me, I have read Foramen Magnum decompression literature. I have introduced Foramen Magnum decompression for the first time in the literature. I introduced that you should not do bone dural decompression. How many, there is at least 35% failure rate after Foramen Magnum decompression, 35%. I am saying not 35, not 10, 100%. The question is, can you do fixation? Answer your question. Can you do fixation? If you can do fixation, you can treat. And if you cannot do fixation, don't do decompression. That is my suggestion. And also, I will like to tell my dear Moroccan friends, if you have doubt, let this Corona thing finish. You come to Mumbai and spend 1 week with me, 1 or 2 weeks with me. I will show you several cases. I have got visitors from all over the world, because when I present this concept, people argue with me, discuss with me. Now I have published on several articles in the world literature, my experience. So you please try to understand this concept and try to read my articles on this subject.
Thank you. Asfiran and then Dr. Bouzgmout. Asfiran. Enfin, il va se connecter. Najib, Asfiran. On te voit, mais micro. Tu peux libérer son micro, monsieur?
Il est déjà libéré. Professeur Bouzgmout est...
Najib Asfiran, on ne vous entend pas. Alors, on va peut-être passer au docteur Bouzgmout. Et on reviendra vers vous. Dr. Bouzegmoud.
Thank you, Professor Atul, for the invitation. Thank you so much for this didactic, outstanding lecture. I have two questions. The first is a technical one. During surgery, if we have an injury of the vertebral artery in one side, do you decide to continue with the same surgical strategy or to change the material, the approach, and so on? And the second question, what is your experience about anterior fixation of C1C2 instability? Thank you.
I can, I can only tell you that you have a very good experience in this subject. And I am very happy to hear such fantastic questions from you. And these are very fantastic questions because you have a good experience. I am absolutely sure. Now your question number one is, if you damage vertebral artery, then what you do? You see, there is one way that you abandon the operation. I have never abandoned the operation, never in my life. And if I damage the vertebral artery and I complete the fixation on the damaged side, I do not remove my implant and go on the other side. I complete the fixation. If I have damaged the artery, then there is no other, what more you can damage, you complete your fixation. So that is one. And if I have completed the fixation, I will be more careful on the other side, but I will certainly go on the other side and do fixation on the other side with the same technique. But I must also tell you, in my experience over last 33 years, I have damaged vertebral artery on both the sides also in one patient without any problem. So vertebral artery damage is a problem, but it is not such a problem that you have to abandon this operation. You can still continue. You see, vertebral artery is a dangerous thing. If you can have very serious problems. But if it is damaged, you can still continue with the operation and complete the operation.
Okay, I think we will move to Professor Hilmani, and after that we will tell to our friend Atul Gul to stay with us. If there is some question after after the conference of Professor Hilmani, we can ask both of them to answer. Professor Hilmani, are you ready?
Yes, yes.
Please.
I continue my
yes, you continue. You continue your conference at the place where you stopped.
Yes.
I don't remember which slide.
It's okay.
Okay.
Yes.
Yes.
So I am sorry for this technical incident. I continue. I have 2 or 3 slides to achieve my conference. So I say that we have studied 3 or 4 years before 100 patients for assessment width and length of the pedicle, and we have seen that there is some difference statistically, different difference between the pedicle length between male and female, but the difference is not significant statistically about the pedicle width. In general, the size of pedicle and pars, we have this here, the pars and the pedicle, and the width is 8 millimeters. The height of the pedicle is 9 millimeters. The length of the pedicle is about 17 millimeters, but the distance between the posterior edge of the posterior process, the facet, and the anterior edge, the anterior facet is about 24 to 35 millimeters. Those dimension is very important to have in mind before choosing the size of the screws. this the angle in sagittal and axial plane, and we must know that the angle in the axial plane it's about 28 to 18 19 degrees in sagittal plane. So those two, as Professor Atul said, I think that is the most moved articulation after shoulder. There is many ligaments which lead those atlantoaxial and occipitoaxial junction with several ligaments, and we have many different tensile strength, especially in transverse ligaments and capsular ligaments. This allows several three physiological motion in the three-dimensional plane or space with flexion, extension, lateral bending, and rotation. One the most of important points is those moving flexion, especially, and bending, lateral bending, leads to kinking and reducing the size of the vertebral artery. And this is very important to keep in mind, especially in the elderly patients. So finally, I think that if you have a message to give of our young surgeon is to learn carefully our anatomical structure before going to operate this important and complex challenging area with ganglion C2 nerve with its posterior and anterior branch. Sometimes those branches are anterior to the vertebral artery, sometimes they are posterior. But several authors recommend dissection and reduction those branches. Some others we can cut in the branch if there is any problem. Thank you for your attention.
Thank you, Professor Hilmani, and thank you for presenting this very interesting study of Moroccan type of C1C2. It was very interesting. And perhaps should ask to Professor Atul Gul if there's some studies like this in India, and if there's some differences between the two people. This study was very interesting because before Lazort, is French neurosurgeon, was studied the movement of the neck and the repercussion at the vertebral artery and the carotid artery, and he demonstrated that there is some balance in the head to make the irrigation of the brain when we move, and is there some balance? And the question is, what interesting is there is some damage of one artery. Perhaps it will change this balance of irrigation of the brain. And if my question is there some studies like Professor Hilmani did in Casablanca? Is there some studies like this in India, or you are going to perhaps to see if there is some difference, anatomical difference about in India?
I have, there are many studies in India about the facets and about the pedicles and about the odontoid process. But I don't think in Morocco and Indian population, there will be much difference. I think
yes,
we are, our body and shape and our size of your population and Indian size, people are almost the same. I don't see any major possibility of difference. Okay. But this is a good study.
Mr. Hilmani?
Yes, thank you. As Professor Atul said, there is no significant difference, but when we have learned the literature, we have seen some difference between ethnic population, especially in white. The pedicle whites, there is 2 or 3 millimeters difference between Asian and African people. I know that in 2017 it was the first study in Africa, but there is some difference between Anglo-Saxon and Asian patient about white, but not in the land. But there is some difference between this, especially in the parts of the C2. Thank you.
Thank you. Adnan Qasim. He shut his. No. There is one question from India. It's amazing, as I said before. Question to just
Professor Mustarshid raised her hand.
Okay. Just a question from India, Professor Atul. Dear sir, when do you put in spacers?
Yes, spacers is we described these spacers long time ago, but now my indication for spacers has become quite less. And in very rare situation, even in Basler Invagination Group A, Basler Invagination Group B, I rarely introduce spacers. The spacers I introduce when in some cases, some rare instances of Group A Basler Invagination, and in some situations where I'm not able to do C2 pedicular fixation due to vertebral artery situations, I like to introduce as a salvage technique of fixation, I introduce C2 intra-articular spacers. So my indications for spacers have become quite remarkably reduced over the period of time.
Professor Mustarshid?
So thank you very much. I have just to share with you some feeling. Do you agree, or the participant and national participant, do you agree with me that we see less and less craniocervical junction abnormality? I remember when I was in my training, when I was young, we operated a lot of Magnum osteodural decompression, and now we do it less and less. It's my feeling. Professor Azhari, Professor, do you agree with this? In university schools of Morocco?
Yes, we see less. Really, we see less. There is a work in a paper in we did it in Casablanca. I think Professor Lakhdar and Professor Hilmani remember. It's les Arnold Carey. C'était une thèse. It was a thesis of doctoral. But now we see
less and less.
Personally, I see less.
Yes, it's my feeling.
Professor Khamli, Professor Khamlishi, Dr. Bouzoubar, Professor Wahabi, Madame Abadi, and other colleagues can answer.
Yeah.
Moroccan colleagues.
May I say a word?
Yes, please, Professor Khamlishi.
I think that this low frequency is at the departments of neurosurgery at the universities is maybe just something which is secondary to the development of other services of neurosurgery in private practice everywhere. And as in general, it's quite, it's surgery which is done everywhere, and this is the reason maybe less patients are coming to the hospitals, because I don't see any other reasons. I mean, and in such kind of situations, we need maybe some kind of national query. It's very easy. My friend, the Mustarshid, you can just make an inquiry to all services and neurosurgeons in the country, and then have a more clear idea about the situation. But it's difficult, I mean, just to confirm this or not. May I just finish? Sorry, may I add one question to both speakers, and especially to my friend Atul? There is one of complications of this fixation, which is mainly mentioned, is the junction syndrome below the level fixed. Frequency it's increasing with the follow-up, and it's found almost in all papers. You have huge series, more than 2,000 or 2,700. So I think that you can give us really great clarification about this syndrome, this sub-level instability, secondary instability after the fixation.
Yes, let me tell you very clearly that atlantoaxial stabilization, if it is done properly, can give new life to the person, completely new life. The person will get, his hands will start moving in the evening, his spasticity will improve, he can walk better, he can, from a disabled person, he can become a completely normal person. So this operation has got great, you can change the life of the person. But the problem is, if you do not do it properly, if you have don't do it properly, or you have a complication which can happen in any neurosurgical procedure, then can be a complication if you damage the vertebral artery. But I can tell you that learning this operation and avoiding complication is an absolutely important in our business of craniovertebral junction in particular. And the syndrome which you are talking about, I am not aware of that syndrome, but I can tell you that post-operative complication following atlantoaxial fixation surgery are extremely uncommon in my experience of last 33 years. It's quite uncommon, because we are, the entire technique instrumentation is lateral to the neural structures. You're not even opening the spinal canal. The only thing that can get damaged is the vertebral artery, which you should learn to protect. And because you are away from the neural structures, neural complications can be extremely uncommon. I will say without any hesitation and without any confusion that complications can be extremely low and success can be extremely high if this operation is done properly.
Thank you. Professor Mjati.
Thank you, Professor Azhari. Thank you, Professor Atul, for this nice presentation. I always listen to your presentation in Neurosurgical TV. I am very influenced by your philosophy. My question is about bone malformation CV junction. When we have small cerebral fossa that can't contain the cerebellum, does your approach philosophy change?
You see this small posterior fossa. You know what? I will request our organizer to let me give one more opportunity when I want to talk on Chiari and small posterior fossa and Basler Invagination. You see this small posterior fossa or tight posterior cranial fossa. This is a very common concept, tight posterior fossa. But my feeling is, it is not like craniostenosis. Tight posterior fossa is not a primary process. What happens is there is a vertical reduction in the height of the posterior fossa, and there is anterior posterior and transverse increase in the height. So vertical reduction, anterior posterior and transverse increase in height. There can be short neck and there can be short head. The head can also be short. And these are all secondary manifestations of atlantoaxial instability. I will suggest that you please read my many articles on this subject. I have got several articles on this subject. You will get more information. You see, it is difficult for me to give you exact pointed answer, but my answer is opening of the posterior fossa, foramen magnum decompression, opening of the dura. These are all negative operation. My request to you will be, please do not do these operations, foramen magnum decompression in particular.
Thank you. Professor Aithun Ali?
Sorry, I have another question. Professor Atul Gawal, can you please make some comment about patients who present Down syndrome?
Down syndrome is a very common entity. Down syndrome is very commonly associated with atlantoaxial instability. I have treated at least 50 patients with Down syndrome. And Down syndrome are commonly associated with atlantoaxial instability. There may be bifid C1 arch, there may be basilar invagination, but all Down syndrome patients need atlantoaxial stabilization. And they can have a very beautiful life after atlantoaxial stabilization Down syndrome.
Dr. Bouzouba? Dr. Bouzouba, active ton micro.
Yes, just to try to answer Professor Mustarshid about the number of cases of instability. You heard me?
Yes.
Yes. But in 1980, at the beginning of my neurosurgery, we were not more than 20 neurosurgeons in Morocco. And now, as you know, we are about 250. So we should make really data in order to answer your question. But I don't agree with you that they are less, because there are many neurosurgeons and also there are many centers. In 1980, there are only 2 centers in Morocco.
Thank you, Dr.
Now,
Bouzouba.
What
I said is we see less. It doesn't mean there is less.
I want to answer this question.
Please.
You see this question, whether we are seeing atlantoaxial dislocation less. This is the question. And I can tell you that atlantoaxial instability is the most under-recognized clinical entity in our subject of neurosurgery. Atlantoaxial instability is the most under-treated clinical entity in our subject. Do you know that atlantoaxial instability is very commonly associated with ossified OPLL? Very commonly associated. Do you know this? You see, we don't know. That is why we don't treat. Do you know multi-level spinal degeneration, cervical spine degeneration is very commonly associated with atlantoaxial instability? Do you know atlantoaxial instability is very commonly associated with Hirayama disease? Do you know cervical kyphosis is very frequently associated with atlantoaxial instability? So my answer to your question is that we should know atlantoaxial instability better. We should learn atlantoaxial instability better because we are under-recognizing this entity. We are under-treating this clinical entity. So that is my answer.
Thank you. Dr. Hakko, is there some question before conclude?
There is Dr. Ahmed Nasir.
Ahmed Nasir, Professor Hilmani before.
Professor Hilmani. Thank you, Professor Goel. My question is about your concept. I don't like philosophy. Philosophy is based on one feeling without veritable science, veritable scientific criteria. I prefer concept. So, according to your concept, for Chiari malformation or Chiari formation, as you say, as you prefer, if you choose or you prefer to fuse all cases with or without syringomyelia, because in some patients without syringomyelia, when we decompress, there is a good recovery. We have a good recovery without fusion. So if this the concept which you defined, it's really. Thank you.
Now my answer to your question, you know what, it is a very, I can understand. You see, the whole world today is still trying to discuss this issue. I am giving lectures on Chiari malformation all over the world. And also I am getting several patients from all over the world who are I am treating. You see, I have now treated more than 550 Chiari malformation in 10 years. And you have to just believe what I am saying. And I am telling you that I will give you one more presentation when our organizer, moderator will organize another conference where I can talk only on Chiari malformation. Today was I just showed you 3 or 4 cases of syringomyelia. So whether there is syringomyelia or not, whether there is bone abnormality or basilar invagination or not, Chiari malformation is a manifestation of atlantoaxial instability. That is my concept. Of course, when there is tumor and Chiari, that is a different issue. See, hydrocephalus and Chiari, that is a different issue. Lumbar tethered cord and Chiari, that is a different issue. But Chiari malformation as such, with or without syringomyelia, with or without bone malformation, is always a manifestation of atlantoaxial instability. And if, of course, if you are having any doubt, and you must have doubt because you by decompression, I give you a very open invitation to spend 2 weeks with me. And I will convince you 120%. Don't worry about it.
Thank you. Dr. Haku, is there one question from Kenya? Could you read it, please? Could you read it?
For Professor Atul, you explained the concept of Chiari 1 malformation being a formation. Please expound in background of atlantoaxial instability.
So I can see that my entire presentation is now focused, questions are focused on Chiari malformation. I was talking on fixed dislocation. I was talking on rotatory dislocation. I was talking on basilar invagination. I was talking on distraction, but all the questions are focused on Chiari malformation. Chiari malformation is, you see, there are several articles of mine which I will request you to please go through, because this is a complex subject and it is very difficult, for the people who have been doing foramen magnum decompression to tell them. You see, I will ask you one question. You do foramen magnum decompression and the patient does not recover or patient does not improve, then what you will do? You see, if you see the literature on foramen magnum decompression, there is 35% failure rate in foramen magnum decompression. You read the literature. Now, if there is a patient has not improved, then what is your treatment? You have no treatment. And I have got several patients in my series now who have failed foramen magnum decompression and they have undergone C1C2 fixation. Don't be confused. This is my very friendly and brotherly suggestion to you. Don't get confused. You just try to understand more, try to learn more, and try to think a little bit differently rather than decompression. What decompression? There's no meaning of decompression. It is complete waste of surgery. Complete waste of surgery, believe me.
Thank you. Last question is Ahmed Nasir. Last question, Dr. Haku, because we have to conclude.
Yes. Ahmed Nasir, you can speak.
Yes, my question is to Professor Atul Goel. Excellent presentation. I'm following from Kenya. I wanted to ask, you just mentioned something about Down syndrome and atlantoaxial instability. In terms of experience, at what point do you decide to do, at what age do you decide to do surgery for atlantoaxial instability in Down syndrome? And do you do it when the patient becomes symptomatic or on radiological? Thank you.
See, whenever there is radiological problem, we do the treatment. Suppose there is atlantoaxial instability and no symptoms. So no symptoms means if there is an unstable spine, he will become symptomatic very soon. So unless he's completely asymptomatic and there is, doubtful radiological presentation, we can wait. But, if there is a reasonable radiological disability and reasonable, even mildest symptom, I will do, because it is such a safe operation for me, because, I have been doing so many of these cases. So it is very safe operation. Of course, for those who don't have very good access to this technique and those who are not very familiar to C1C2 fixation, and I will suggest one thing. In Down syndrome, you include occipital bone in the fixation, a very negative operation. Don't do occipital fixation or C3-4 fixation. Those are very negative operation. Don't ever do this. If you cannot do C1C2, don't touch the patient. That is my recommendation.
Thank you, Professor Atul Gul, and thank you again for your conference. Some of us know this conference, but it's very nice to show your experience to our young colleagues or all over Africa or the Maghreb. Thank you again for this conference, and I hope you will see you in other conference and perhaps in Bombay. We don't know. We just wait to be patient to have some flight to Bombay.
Tomorrow.
It's not before 6 months, I think. But
Tomorrow I am giving one webinar, 1.5 hour lecture. Tomorrow I am giving on Chiari formation tomorrow.
Okay.
And
okay.
I will send to the organizer
please.
my link. Just now I will send. And
Please.
I will request him to send the link to our other members who are here and want to know more about Chiari formation. And I will be very happy if you can participate in my webinar tomorrow.
Great.
With pleasure, with pleasure.
So thank you, and thank you, Professor Hilmani for the organizing and for the conference. It was very interesting for understanding, and I tell to Professor Mustarshid to say some words to conclude, and to tell to Professor Hilmani as a president to conclude. I will thank Dr. Haku and Dr. Buzgmut for the coordination, and thank you for the attendance for all friends and for everybody. Professor Mustarshid.
Thank you, Professor Azhari, dear colleague, dear guest, our honorable guest. At the end of this webinar session, I will to thank you very much and to share us a great experience, and to I have assisted to your presentation many years ago, and I know this concept, but many of the young neurosurgeons discovered in this session. Thank you very much for your excellent high-level presentation. Thank you, Professor Hilmani, to share us this anatomic, and thank all of their colleagues to share their questions and their comments. So we were waiting for your links to your next webinar to be shared with our colleagues. Thank you for our neurosurgeon. Thank you, Professor Azhari and Professor Hilmani.
Thank you. Bye-bye.
Thank you, Professor Atul, for your participation and sharing with us your great experience. And I am sure that we will see you shortly. I say shortly, inshallah, for one other topic, interesting topic. Thank you, Professor Azhari, for your very nice moderation. And I will many say many thanks to our coordinator, Professor Mustarshid and Professor Benzgemout. And I don't forget our best friend, Mehdi Hko, Dr. Mehdi, for his technical support and the good job we do. Thank you, and thank you all for all participants for their attending. Thank you, and see you.
Thank you very much. Thank you very much, Professor Hilmani. I thank all participants and Professor Azhari for moderating this this webinar. Professor Mustarshid and Professor Benzgemout to coordinate with me, and Professor Atul to present this outstanding presentation. And I inform all bodies that our next webinar will be the next Tuesday, 9. Join with Professor Juha Hernes Niemi, and moderated by our master Professor El Khamlishi.
Okay, thank you, Mehdi. Thank you, all of you, and take good care of yourself.
Thank you. Bye-bye. Bye-bye.
Hilmani, can I say something? Dr. Hilmani?
Yes.
I'm Dr. Wafa from Cairo.
Dr. Wafa, our best friend. Welcome.
I would just say hello, and I enjoyed these two lectures very much. Thank you. I will be looking forward for this lecture about the Chiari malformation. See you soon, Professor Goul as well. Thank you.
Thank you. Thank you.
Thank you, Professor Wafa, for attending.
You can send me the link. I will diffuse this.
Right.
Okay.
Professor Wafa.
Yes.
We will have some webinar with us, huh?
Right? Yes, sure.
Sure.
Waiting.
This is promise for you.
Waiting for you to organize.
Okay, I wait your proposal for organize a meeting with Arab spine and Egyptian spine surgery. Why not?
Yes, why not? Looking forward for this.
Thank you.
Bye-bye.
Thank you for attending. Dr. Professor Lakhdar, you're where is Professor Lakhdar, our president of Moroccan Neurosurgical Society? Is that? Okay.
It's not there.
Okay. Thank you, Professor Atul. Professor Atul.
Thank you.
Professor Atul, what's your next topic for us?
I will talk on degenerative spine.
Degenerative spine, cervical or
degenerative, full degenerative spine.
Look, we will choose one region to be more precise, please.
Okay, you choose cervical.
I will contact you next time. Okay, thank you for your
thank
you very much.
Thank you. Bye-bye. Bye-bye.
Thank you.
Thank you. See you later.
يعطيكم الصحة.
شكرا حمادة. شكرا. Where are you from?
أنا جزائري وراني في السعودية.
مرحبا.
الله يحفظك.
Enjoy your stay.
شكرا الله يحفظكم.
Mustarshid, thank you.
Thank you. بارك الله فيكم.
دكتور حكو.
وي.
دير لك لاغيير فون.
لاغيير بلون تمشي للفيديو.
دير ليه؟
تمشي الفيديو.
زيد.
Donc il y a une flèche à côté à droite.
زيد. ها هي.
Il faut cliquer sur cette flèche. Ils vont dire choisir un arrière-plan.
Un fond virtuel.
ولا un fond virtuel, oui.
ومنين تجيبو؟ تكون ديرو في الفوتو في الاورديناتور؟
تكليكي عليه يقول لك il y a une plus. Il faut ajouter un plan ou des plans qui sont déjà sur le zoom.
صافي الله يعطيك الصحة.
مرحبا أستاذ. مرحبا. À bientôt. السلام عليكم.
شكرا.